Blue will kind of reduce the critical flicker frequency of artificial lights.
Okay.
It also can dampen the challenges with scrolling sensitivities. So if you have someone scrolling on a screen, you'll show them a tint of that color. It often makes it a lot easier for them.
Hello, and welcome back to another episode of the 2020 podcast, Canada's #1 optometry podcast. I am your host, Dr. Harbir Sayan. Thank you so much for taking the time to join me here, guys. I'm so grateful for all the support, for all the liking and the sharing and everything that you've done to help the podcast grow. As always, I'd like to ask one big favor off the top, which is if you get some value from this episode, please do share it. Put a link on LinkedIn, send it to your friend, put it on Instagram, text me, let me know that you loved it. I always love to hear that and I always appreciate all the support. And I have a wonderful guest here today. First of all, we are in beautiful Kelowna, British Columbia. We are inside Okanagan Vision Therapy with Dr. Paul Rollett, and I'm so excited to talk about vision therapy. I don't think I'd ever thought I was going to say that sentence, but I am actually really grateful to be here and tap into the brain of this man here too, so we can all learn more about vision therapy. Dr. Paul Rollett is the owner of Okanagan Vision Therapy, which has locations in Kelowna, Vernon, and Nelson in British Columbia, where they provide high quality vision therapy services. He is also the father of 3 beautiful children and the husband to Dr. Brittany Rollett, who is, of course, the amazing BCDO director member as well. I wanted to give Brittany a shout out. And self-proclaimed avid bad golfer, outdoorsman, and wearing Birkenstocks. He didn't want to show it, but I have to show it. He's wearing Birkenstocks today because the outdoorsy man has injured himself.
Yeah. I'm getting
playing
old.
basketball,
That's
golf,
what I'm saying.
motorcycle accident.
Yeah. Major motor.
Some sort of masculine activity.
Incident. Yeah.
Okay. Well, thank you for doing this, Paul. I really appreciate it, man.
You.
Thank you for doing it. So I told you, we talked over the phone. I have very little knowledge and background in VT. So I've almost avoided these conversations, particularly on podcasts, because I don't want to look silly. But I really appreciated our conversations beforehand because I really got a good sense of, or at least start to get a good sense of what you actually do and the impact that you really make here. And I wanted to get into that. So our colleagues, because I know I'm not the only one who's not into VT, right? So I want some of our colleagues to learn a little bit about what you do, how it works, and then what we could do maybe a little bit if we wanted to dabble a little bit. So why don't we start, if you wanted to give a bit of an introduction of yourself and your beautiful practice and what goes on in here.
So I'm obviously an optometrist who has a very special interest in vision therapy and visual rehabilitation. We have been dedicated vision therapy center for almost 11 years now. And so our whole practice has been built around kind of 3 main groups of clients. So probably the bulk, or at least maybe 50%, would be people who have sustained head injury or concussion, whiplash, stroke, and are dealing with sort of the visual sequelae. So light sensitivity, motion sensitivity, dizziness, challenges with reading. Then a big bulk, probably 40% will be kids. So a lot of pediatric work, whether we're, working with amblyopia or if we're working on reading and learning difficulties, that's a big part of it. Children in grade 2, 3, 4 who are struggling with the development of reading skills. Right. And then kind of a smaller percent, maybe 5 or 10%, a little more in the summer, is sports vision training. So we'll work with athletes, we'll do goaltender camps, we'll have, baseball, golf, and hockey are the big sports around here. So we'll work with people during the summers primarily to help optimize their game and take it to the next level. So those are kind of the big group of clients that we work with. And it's no day is ever the same. It's always a fun, enjoyable puzzle, which for me just keeps this profession really rewarding.
I love that. I mean, just looking around the office, we got these little things hanging from the ceiling here. We got nets and lights and other things in the background. It's kind of a cool space.
Yeah, thank you.
So I'm really excited to kind of dig into what some of these things do and some of the patients that you see. Let's talk a little bit about the types of actual activities. What are these for? And what are some of the other activities you do for some of the bulk of your patients? Let's start with kids, for example.
Right.
Learning, reading difficulties and things like that. Let's say I have referred a patient to you as a young patient. What are some of the early steps of what you might go through with that child?
In the initial assessment, we're going to be looking at optics, which tends to be, one of the, critical components to consider. A lot of kids who are struggling may have difficulty with accommodation, ill-sustained accommodation, convergence. And so we're looking, is there anything that we can do with glasses or optics to maybe reduce some of the stress or strain while they're reading.
Mm-hmm.
So we usually will start with that. We'll give them a handful of weeks to months and then come back in. And from there, if we're still dealing with issues, which a lot of times you'll see improvements, but certainly not necessarily as much improvement as you might need to become a strong, fluent reader, then we'll bring them into a training program. And so the programs are generally, they're going to be quite individualized, but the general core principles is each week people will come in and we usually work through 5 different categories of activities. One is going to be an accommodative activity. One is very commonly going to be a vergence or an eye teaming. One is going to be an oculomotor, so scanning or eye tracking. And then we'll often have some of the fun activities as a 4th category. So we'll use virtual reality, we'll use 3D TVs to help build vergence ranges. And then we usually also, we have an occupational therapist and some kinesiologists who've been on the team. So we also may incorporate gross and fine motor activities just to round it out so that, the kid isn't necessarily just sitting there doing eye activities.
Interesting.
A lot of times you'll have to incorporate movement and motion. And so we may borrow or incorporate movement or gross motor activities. And so that's generally, most people usually are with us for, around 15 or so weeks. And we'll kind of sequence or structure each week and send them home with activities. So
that's really interesting. The gross motor movements, the kinesiology, occupational therapists, you find that those are needed or relevant for a child who has, or it comes to you for reading issues. You find that there's a connection between some of that?
It depends. And we often, again, because we have an occupational therapist, we may actually do a gross and fine motor assessment. I think in terms of the way that the muscular systems or coordination develop within our body, it's initially gross and fine motor that are developing somewhat in tandem, maybe a little bit more of the gross motor. And oculomotor actually doesn't develop until a little bit later. And so if you're dealing with a child who maybe has low tone or challenges with movement or coordination of the rest of their body, it's tricky to get them to sit still and do, let's say, an eye teaming activity until you've maybe helped them in that area. So that would either be something we may do, or we also collaborate and refer a lot with local pediatric OTs or physios. There's a lot of good resources. So it may be that they have to do some of that work before we start to work on the visual system.
Gotcha. Very interesting. See, I thought, okay, let's just work on getting your speed, making sure you can keep things in a line. But there's actually potentially a much bigger picture that you need to be looking at.
Yeah.
What's up, guys? I want to just take a second to thank our partner for this episode, Hoya Vision Care Canada. Hoya empowers eye care professionals to achieve their business goals through comprehensive training and regular business review. Their super high vision Mirio EX4 is the latest innovative anti-reflective coating that has set new industry standards for clarity and durability. Also, their award-winning myopia management lens, MyoSmart, has sold over 4 million lenses worldwide. To learn more, contact your local Hoya territory manager today and elevate your practice. And now back to our episode with Dr. Paul Rollett. Let's go back to the other big portion of your patient base, which is your concussion, head injury, that type of a patient base, which is often what I think many of us will associate with vision therapy as well, vision training. I know you said this already, each patient is very individualized. There's going to be individualized programming for each of them, but maybe an average case, if there is such a thing, of a patient who's had a head injury and what the process might be for you to diagnose and then come up with a treatment plan?
Yeah, so people will initially be referred in primarily. We're fortunate we support our local OD community quite well, so we do get quite a lot of optometric referrals where people will come in. And initially what we're taking a look at, our initial exam is usually 75 to 90 minutes, where we're doing kind of a full binocular vision workup. So stereopsis, vergence ranges, saccadic tracking, accommodative vergence. You're kind of getting the whole picture.
Right.
And then what we're often doing is we're trying to determine what we can do optically to help settle or reduce some of the symptoms someone's dealing with. So many of our patients are dizzy. So it can often be a matter of what can we do to change their optics that might reduce some accommodative demand. So it might be reducing some of the minus in their glasses. Okay. If they have a vestibulo-ocular reflex difficulty, so they're looking at the letter chart and they kind of shake their head and everything goes blurry, then what we often might look at is trialing some yoked prism in different directions, whether a little bit of base-in prism, sometimes yoked base down because of the magnification impact. You'll put it in front and we'll have them walk around the room. We'll have them looking at letter charts and just ensuring that, okay, when they moved their heads before, they lost 3 or 4 lines of acuity. Now it's only 1 or 2. So we know that what we're doing optically is going to be helping the visual and vestibular system to work better together. And the third element is so many of our clients are quite light sensitive.
Yes.
So we're trying to look at, many will come in wearing dark sunglasses. So we're often looking at, is there a different tool or a different tint or a different step that might allow them to, be in busy indoor environments that, they don't have to wear dark gray sunglasses? Is there kind of an intermediary step? So we'll be looking at different tints to help with that.
That's excellent. I know there's a lot there, and we could probably unpack and spend some time on each of those things. But I want to ask you about yoked prism in maybe a little bit later. But I want to stick on the tints and would you say tint and a filter are they different things? Tint versus filters?
Yeah, it can be. So filter is usually going to change sort of the incoming wavelength or sort of the spectrum that's emitted, whereas a tint is a little bit more of a color, like an actual color change.
Okay.
And so we'll often be utilizing, to be honest, a lot of tints or colors, which can have a variety of different benefits. A lot of times the ones that people are drawn to, especially after a head injury, are usually a little bit more of kind of your shorter wavelength colors, your blues, your purples, maybe something along, sometimes green. And so we may be trialing for a couple of reasons. Blue will kind of reduce the critical flicker frequency of artificial lights.
Okay.
It also can dampen the challenges with scrolling sensitivities. So if you have someone scrolling on a screen, you'll show them, a tint of that color. It often makes it a lot easier for them. And part of it,
a blue tint or something with a blue tint will help improve their ability to scroll or reduce the sensitivity to that.
And it's worth looking at. And there's a number of theories kind of around what that is. It may be kind of an impact on the light that's emitted. It's also, if we think about our red-green balancing, blue is actually going to act a little bit more like a bit of a plus lens.
Oh,
so it's actually, similarly to how we, if there's a red, you add a little minus. If there's so if you kind of go more into the blue end, you're actually adding just a touch more plus.
Very interesting.
So there's likely that component as well too. And it's not that everyone is going to benefit from those, but you're really going to be looking at, if they're quite light sensitive, then you want to probe and kind of gauge the response. And so that's a lot of what we're doing initially. So once they've done that and we've maybe determined some optics that have been allowing them to feel better, then what we're going to do is we let them go out into the world with that. Usually about 4 to 6 weeks. We often don't do a whole lot of active training initially because we just kind of want to, we'll say, go for walks, continue the other rehabilitative activities you're doing. And then we have them come back in and we'll remeasure where things are at, and we'll consider vision therapy if needed at that stage.
All right. Yeah. So you mentioned blue light for certain variables. How about on the other end of the spectrum? Like I know FL41 is a popular color, that kind of rosy color tint. Is that something that you often use as well? And what types of patients would those be for?
It's a little bit more researched, I suppose, within kind of the migraine or sort of headache community, and it can certainly be helpful. There's been some changes in terms of percentages. Sometimes patients might find it a little bit too dark, so you're going to have to kind of explore how they're actually feeling with it. But fortunately, there's great optical suppliers who've been able to change some of the percentages to make it a little more tolerable. So FL41 is very common, and we actually will often have flippers. We'll have one that might have a little blue, one that might have a little FL41, and we'll gauge. I usually tend to find myopes might be a little more drawn to FL41. Hyperopes a little bit more to blue, but that's just an anecdotal experience. So I wouldn't take that to the bank. It's just sort of
everybody write that down.
Write that down.
If it doesn't work,
it's gospel.
Okanagan Vision Therapy. I'm just kidding. I'm just playing.
That's just been.
But that's very interesting to hear from your anecdotal.
Yeah.
I mean, of course, you've had a lot more experience doing this than many of us, me, myself, and maybe many of us listening, watching. But very interesting to hear that. Like I just personally never understood or realized, I should say, is more appropriate, that just changing the color of a lens could have such an impact on your visual system, ocular, that reflex there. That's very interesting. So obviously a lot of what you're talking about requires lenses, ophthalmic lenses. I'm curious to know how you go about finding a partner vendor in that scenario, to find somebody who works in such a unique space, who can work with you well in this kind of a space.
Yeah, I mean, for us, it's, kind of from early days, it's all about finding sort of an optical partner that is willing to kind of come in and take the feedback of people who are on the ground and noting these sort of observational changes with a variety of different tints. And Hoya in particular has been, from the start, has always been so open to taking the feedback of people who are on the ground. And so I think initially, you'll go to different courses or you'll read some research on different filters or tints, but it might be hard to access, or the reproducibility is not always easy, particularly with tinting. If you change the color of a lens, if you also are adding an anti-reflective coating, which is usually what you want, it's actually quite a unique titration, because you need to have a little bit darker tint, because the anti-reflective will wash down the percentage a little. Working with someone who's, like I said, Hoya has been wonderful in the sense that they actually have been able to titrate out how much to start with the tint so that you wash out the right amount, so that you don't get something that's too dark or something that's too light. And so this is kind of across the spectrum. And I just think they generally have been a really nice partner. They're very open to feedback and very open to creating solutions that providers on the ground are noting. And I think that's where the evolution of the evidence base always comes, is in any field, it's people who are seeing a wide variety of one particular type of patient and are noting that, I'm getting this really positive response. Let's maybe do this on a larger scale. Let's kind of develop a research study, which we've always been very committed to. We're always part of a research study pretty much since we've been started. And so it's just been nice. In order to do research, you need the tools. And so they've been really helpful in terms of getting us what we need.
That obviously makes a lot of sense. Have a partner, now that you said it, it seems obvious. Have a partner that's actually going to take feedback, make changes, create a product that fits what you need, not just like, here's what we have, you figure it out now, which wouldn't really work, right? You wouldn't be able to treat your patients if you didn't have the appropriate lens.
Exactly.
And I had no idea that adding anti-reflective coating changed the density of the tint or whatever you're saying. That's really incredible.
Quite an art form to do
it sounds like it.
It's quite an art form.
So in some of these publications that or the research that you're working with, it's specifically these lenses that you're having manufactured from Hoya that are being used in this research.
Yeah, that's kind of our next wave. Right now, we're finalizing on Yoke Prism, which I know we talked a little bit about. We've done vision therapy research, nutrition. Actually, one of our colleagues here he's very into, he's a fellow of the Ocular Wellness Nutrition Society. So we're looking at how different carotenoids can impact light sensitivity, these kinds of things. So we're always trying to progress the evidence base.
That's really great to hear. Now, so we talked about tint and for Hoya kind of supporting you in that sense, like with these different shades and densities and so on. In Prism, again, me with my limited knowledge in Prism, how important is it? I imagine it is, but I'd like for you to describe to me how important is it to make sure that a lens is made in a way to induce a certain amount of Prism or not induce a certain amount of Prism. I know Prism thinning is a term that I should probably know more about. So I would like for you to tell me a bit more about that.
Yeah, it all comes down, when you're doing Prism, a lot of times when you're doing smaller amounts of prism, you actually do want the prism kind of ground into the lens as opposed to pupillary decentration. You want it kind of within the whole lens. So working with a partner that, does that, and you can communicate that. Prism thinning is also another common thing that you want to be in conversation with your labs about. Most progressive lenses, in order to make them thinner, are going to be inducing between 1 and 3 diopters of yoked base down prism primarily, which many times with concussion patients can be a little bit too much to handle. The general population can be fine. Otherwise, they may not be. So when you manipulate the prism thinning, then you often have someone who's looking through maybe a less distorting prism. So it can be an easier step with their new glasses or their optics.
Very interesting.
Yeah.
So much to learn from you, Paul. And I hope everybody who's watching and listening is getting some of this. Right? Go back, listen to it again, write it down, especially the part that Paul didn't want you to write down about the blue for the hyperopes or the myopes. I messed it up already.
That's just,
just listen to me. You'll get it wrong. It's all good. Okay, listen, one of the things about VT, I know, and I know there's a fair amount of skepticism amongst, even just within our own profession, amongst our colleagues and beyond, as to like, does it work? Is it voodoo? Is it real? So can you help me understand, and anybody who might be a little skeptical, as to like, how do we gauge success in VT? How do we know it's working? What kind of metrics and measurements are you looking at?
And I think this is the right question to ask, because the reality is, as with anything, initially you're going to be looking at, are you solving the problem that brought someone in, right? So you're looking at symptoms of light sensitivity, dizziness, motion sensitivity, balance challenges, reading. Are you actually building reading endurance? And there are questionnaires where you can actually gauge that you're moving in the right direction.
Right.
For us, we're pretty anchored on some of the well-established norms of visual function and getting them to where we would expect them to be for someone their age. So the big things are normalizing stereopsis, 40 seconds of arc distance in near is a big part of one of our goals. Big one is normalizing vergence and accommodative flexibility. So a lot of people will come in, and when you ask them to transition from near to far using lenses, they can do it 2 or 3 times without getting double blur dizziness. We're looking to try and get that 15 to 20 cycles per minute. Tracking, so we might use King Devic or the DEM saccadic tracking tests to make sure that we're getting within normal limits, as well as some infrared eye tracking too as well. And so you're looking at all of these categories, vergence ranges, seeing that their base out break is 20 plus, base in break is 20 plus. Going back to sort of all of these Morgan's norms tables that we've all forgotten.
Yeah, they're all coming back to me now.
They're all slowly flooding in. But I really do think that in order to continue to build the legitimacy of what we do, it's important, and we're a very data-oriented clinic, so making sure that once you have those elements normalized and you've seen that for an extended period, you almost always will see a very large reduction in someone's symptoms, and that's usually when we might transition someone to maintenance. So, again, most of our clients, we're trying to do 15, maybe 20 sessions if necessary, if it's quite severe. But usually by that time, they've kind of learned a lot of the tools and they can do some more of the work at home.
Right.
So, yeah.
That's excellent. So there are norms and standards and things that we're trying to achieve, bring everybody in. A lot of that is coming back to me now. Last time I talked about any of that was back in school, which has only been a few years, right? But, you answered it actually yourself, but I wanted to highlight. So when you do find most patients, in general, I'd say patients, when they do fall within those norms, when you're able to bring them back to those norms, subjectively, they also start to, notice they also feel better.
Oh, absolutely.
Right. It's nice to be able to say, to kind of prove, again, objectively, subjectively, this is working and kind of quiet the naysayers a little bit or the skeptics a little bit. All right. Awesome. That's amazing. Thank you for giving us a little bit more of an insight into what you do here and how you gauge success and all these things. But I'd like to be able to take a little bit, again, understanding that majority of our audience is maybe a little more along the lines of what I'm doing, primary care, maybe specializing in some other areas, not deep into VT. What suggestions would you make for someone like myself who might want to do a bit more to help my patients? I might prescribe a little bit of prism here and there. I might try to reduce certain binocular vision issues that patients might have, but I'm not doing even a fraction of what you're doing here. Are there other ways that we might be able to do a bit more in a primary care setting before we refer over to someone like yourself?
It really does kind of come down to, I would say, maybe 3 different approaches or 3 different, pillars that you maybe want to focus on. The first one is probably a slight shift in terms of how you utilize optics. Because I usually often find that probably 50, 60%, and again, don't quote me on this, is the same as the FL41. Don't write this down, but 50 to 60% is often what has been done optically or what changes you make optically. And so I find that's often a really good first step. And there's a number of great courses. One of the ones that we just hosted here, and I'm always happy to promote, is Dr. Peddle and Dr. Bond out of Ontario. They run a wonderful, it's called a neurofunctional prescribing course. And it really does, it's a great way in the sense that it shifts people's perspectives. It gives them an algorithmic approach because optometrists are very myopic, and so because of that, they are very into details and data and systems. Step by step. That's really kind of as a community. And so kind of need the step by step, which we all do. I think that's helpful. And so you come out with like I said, a little bit of an algorithm where you can actually explore how, again, different tints, different directions of prisms, how these things are actually going to impact on the ground. And you can explore it in any primary care office, and it can make a big impact. So maybe getting a little bit of a baseline, like I said, a shout out for their course there. I know we host it here, and usually once they're coming next year as well, but they do it a lot in Ontario. The next thing is probably community, which I know we talked about a little bit. You mentioned that there can certainly be some naysayers, or there can be some pressures against you and what you're doing. You almost need a little bit of not a safe haven, but a group of people who are providing this type of care, who are innovative, who are progressive, who are pushing the evidence base. And so there's fortunately a lot of great groups that you can become part of to get that community and almost try to find a mentor, right? I mean, we do consulting here. So we've worked with a number of clinics in Canada where we start where they haven't been doing VT and kind of help show them how they can build that up, which is great. You'll find lots of other people who can be helpful in that space. Vision Therapy Canada is great. It's a good community. I would say going to their conferences, COVD conferences, there's the OEP courses, there's the SANET seminar series. I mean, we draw from everyone so that we can kind of have as many tools in the toolkit, but those ones have been absolutely incredibly impactful for me and doing our fellowships and all of those kinds of things. I think that those are great, but once you get the optics and then you get the community, now you sort of need a resource of, okay, maybe I want to do some chairside vision therapy. I want to learn more about the activities. Mm-hmm. There's a company I've been involved with that's based out on the island. Dr. McCrodin had started it called Neurovisual Trainer, where there's a collection of essentially all of the vision therapy activities that you can do. There's about 120. We donated, I think, 70 videos because we had shot basically a step-by-step of how to do all of the VT activities. Okay. Doctor accounts, it doesn't cost anything. You can go on there and you can look through all of the different activities. You can assign them to patients. Oh, wow. There's also interactive activities, so random dot activities, saccadic activities. So one of the things, if people are kind of looking to get into it, is I do find that now that people will often say now that people are busier, it's harder for them to commit to their vision therapy homework. Mm-hmm. But I actually kind of disagree in the sense that I find that now that people are busier, they actually need a little bit more of the structure of either coming into your office or having a virtual phone or check in with them each week, because that accountability tends to continue to keep people on the right track. Yeah. So between those kind of three resources, you can usually get a nice base. Again, you can feel free to take a look at all these activities you can assign to patients too as well. So it's it's been a great tool, and there's more kind of education modules that'll be added to it in the next while.
That's incredible. Neurovisual Trainer.
Yeah.
.com.
Yeah.
Neurovisualtrainer.com, just the way it sounds.
Yep.
It's free?
The doctor account. So if you assign to patients, then there is sort of a monthly fee for them to have access.
Got it.
But you in your office can learn, you can look, you can view, you can play, you can explore.
Very cool. Wow.
Yeah, it's used in universities, and it's actually now in about 4 different languages. So it's been a good resource. I'm just proud to be affiliated or part of what they're building.
That's really incredible. Yeah. Well, thank you for sharing that. Along the way now, throughout this conversation, you've mentioned optics a bunch of times. One thing I want to ask you, so talking to other colleagues who are into VT or into like binocular vision type things and using different tints and so on, V2, for example, being one of the bigger names in it, but even others, I've heard over and over now, multiple times, that we are doing optics wrong. So like, almost like to put it kind of bluntly, like, were we taught optics incorrectly in school? What are we missing and what's different right now?
Yeah, I probably wouldn't go on record for me personally saying we're taught it wrong, but I know exactly where you're getting at. I think the reality, the way that which we're taught optics is primarily with the aim of reproducibility. And what I mean by that is you need to teach optics in such a way that you can take 80, 23-year-olds, put them in a room, and within 3 to 4 weeks, they can all get plus or minus the same answer, right? It's reproducible, has an endpoint. Sometimes what it misses, particularly if you're dealing with someone who has dizziness or balance issues, is you can miss some subtle elements of nuance, because as much as we know about how optics impact the end result, so this 20/20 vision, when you start exploring different things about, again, utilizing prism or strength adjustments, and you start incorporating head movements and motion, it's quite unbelievable to see how subtle nuanced changes with optics will impact someone's performance. And so I think the general principles of optics are certainly sound, but I think the longer you practice, you start seeing these patients, you're like, I feel like I should be able to help them, but I don't know how. Yeah. And a lot of times it can be subtle adjustment to optics that makes such a big difference. So much of our world is processed visually. How our eyes integrate with our inner ear is, such an important element for stabilizing ourselves in space. And so that's why I'm often, encourage people to, at least maybe even reach out to someone who is working with a lot of people who are dealing with dizziness or balance issues and learning a bit more about it. Because the fortunate thing is it's not a total new script. Yeah. It's really just another chapter that you add, and you can open to that chapter when you need it, and you can go back to the core principles when you don't. But The other thing is when you start prescribing a little bit more functionally, your remake rate goes down. Like I probably get one remake every 2 years. It's very, very rare. So there's some financial incentives too, right? So
Sure.
that's what people are looking
Tell
for.
Tell me about that, the remake rate going down and prescribing functionally. Can you explain both of those things to me and how they relate?
I think a lot of it will come down to how are you thinking about astigmatism is a common one there. So not making very large changes, not over minusing your patients, sometimes actually trialing the lenses with motion and movement, because you might be seeing that they find it clearer, darker, and blacker when you're in the exam room, but when they get up and they move, it might be too much astigmatism.
Yes.
So sometimes it might be a matter of rotating the axis to be a little bit more at 180, not pushing them with too large of changes. And also really considering what the person is doing, which I know all optometrists do, but optimizing the tool for the job at hand. What is the actual distance that they're working at? And is there a prism that might be helpful at that working distance? So you take all of those little principles into play, and you'll often just find that the acceptance rate goes up.
Yeah, absolutely. I think, trial framing prescriptions in general can be helpful because then they can move their head around versus behind a phoropter. But I'm sure we've all had that patient who like a quarter extra sill and all of a sudden they're like, well, I can't walk anymore, right? Or that 5 degree axis shift away from horizontal all of a sudden has made them feel really uncomfortable. So we've all had those patients. So it makes a lot of sense. Paul, where can people find you or find some of the resources? Any as far as like resources you want to share or contact information you'd like to share for people?
Yeah, so the easiest way is through our website. We're okanaganvisiontherapy.ca. My email is drrollett@okanaganvisiontherapy.ca, which is a big mistake. Do not have a 14-character tail on your email address. But we also have a contact on our website. So that may be a little bit easier. And if people want to connect, if they're looking to add these services or learn a little bit more about it, or how can they make maybe their chairside or office VT a bit more effective, then I'm always happy to help.
That. So, thank you for being open to connect. And trust me, I feel the pain about having too long of a whatever it is, a URL or whatever. Ours is at highstreeteyecare.ca, and a lot of people get kind of caught up on that. It's too many letters. But thank you so much, Dr. Rollett, for being here. Any final words you want to share? Any other little motivational quotes or something? You just get everybody get out there and yell at your optics professor.
Right. No, certainly wouldn't say that. I always like to end a lot of my lecture. One of my favorite quotes is, if you want to make a difference in the world, you've got to be a little different from the world. And I do think that vision therapy is not a different, entity outside of optometry. It is optometry. And I think that, I've been so grateful for so many conferences are now having vision therapy or optics streams at them, and just continuing to ask that keeps happening, bringing everybody into the fold. It's not, these people are doing this thing and we're doing this other thing, the real optometry, and they're doing a different version. It's all one and the same. And I think that we need to continue to embrace that. And I think that starts at, again, an organizational level, continuing to have speakers come who are working in these fields and sharing their insight, and just everyone listening, being open, because it's vulnerable to share your model on vision, to be honest. But a lot of people have learned a lot of things that can be helpful to your practices. So just, keep allowing us to share the message.
I love that. That's a great quote and a great message to end on it. Thank you very much for sharing all these insights. I hope everybody who's listening and watching was able to gain some value, some insight into what happens in a vision therapy excellence center like this, and what we might be able to do a little bit more to help our patients as well. Thank you again to Dr. Paul Rollett. Thank you to Okanagan Vision Therapy. And thank you to our wonderful friends at Hoya Vision Care Canada for all the support, for supporting this podcast, for supporting me personally, for supporting the profession of optometry. Thank you very much. And thank you to everybody who's listening and watching to the 2020 podcast, Canada's #1 optometry podcast. We'll see you guys in the next episode.